Good afternoon, everyone, and welcome. Thank you for joining us today for the National Hispanic Medical Association's HIV Chapter Forum. My name is Dr. Dora Martinez. I'm the Chief Medical Officer of the Valley AIDS Council down in the Rio Grande Valley of South Texas, where we have the only AIDS service organization providing services for patients living with or at risk of HIV and living along the Texas-Mexico border. And I'm a former NHMA Leadership Fellow. I'll be serving as the moderator for today's event. The National Hispanic Medical Association, NHMA, is a nonprofit association representing the interests of nearly 50,000 licensed Hispanic physicians across the United States. NHMA's mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanic and other underserved populations, in collaboration with Hispanic state medical societies, residents, medical students, and other public and private sector partners. Today, we are joined by Dr. Sara Hurtado-Bares, Associate Professor of the Division of Infectious Disease at the University of Nebraska Medical Center, along with Dr. Julia Garcia-Diaz, Medical Director of Clinical Research Group at Pharmacovigilance PPD, to have a robust conversation about HIV within our communities in celebration of National HIV/AIDS Aging and Awareness Day. National HIV Aging and Awareness Day is celebrated on September 18th, and it brings awareness to issues related to HIV among older Americans, including new infections among older adults and adults over 50 aging with HIV. This chapter forum will be a roundtable discussion with our speakers, who will have the opportunity to answer questions from our audience. Everyone who is watching live today, we ask if you have any question to please drop them in the Q&A box, and we will incorporate them into our discussion. With regard to NHMA's effort in combating HIV, NHMA has partnered with the Centers for Disease Control and Prevention, or CDC's, Let's Stop HIV Together campaign to maximize the effectiveness and reach of the Together campaign by strategically disseminating culturally appropriate HIV resources to the Hispanic community. HIV/AIDS continues to be a significant public health challenge in the U.S. The annual number of new diagnoses decreased 7% from 2014 through 2018. But Hispanic and Latinos accounted for 27% of the new HIV diagnoses. As the largest and fastest growing minority population in the US, coupled with disproportionate rates of HIV/AIDS, Hispanics are crucially important to prioritize in HIV prevention and care efforts. We hope that our conversation today can address the challenges in which people with HIV experience, as well as highlight the importance of tailored HIV care and treatment services among our community. So some housekeeping. So all participant microphones are going to be muted, but please feel free to type your question in the Q&A box. And the recording and slides will be sent out a week after the event and stored on the website or YouTube channel. So learning objectives is to educate health advocates about HIV/AIDS care and treatment among older adults. And so I'm going to open up the question for the roundtable discussion with how has HIV impacted your community? And I'll ask Dr. Hurtado first to comment.
Sure. Thanks so much for inviting me to be on this panel, and I'm looking forward to the discussion. You know, I am fortunate. I live and work in Omaha, Nebraska, where we are a relatively low prevalence state, and yet HIV has significantly impacted many individuals in this community. And, you know, what's most important, I think, for today's discussion is that Latinos are disproportionately impacted in our state. Just in the last year, 50% of our new diagnoses were among Latinos. And so although a lot of our prevention efforts, we have so many effective forms of prevention at this point, and we're reaching many patients with pre-exposure prophylaxis. In our community, we still have a ways to go in terms of reaching minority communities, especially Black and Latino patients.
And how about you, Dr. Garcia? How about your community?
Thank you for having me. Unfortunately, here in the state of Louisiana, we are either number 2, number 3, number 4. We rate in the top percent in the US and have been for a number of years. And just as the African the Black population is affected, so is the Latino, disproportionately to the other populations. So we probably don't do enough to reach out for testing and identifying those patients. So unfortunately, we have a number of those patients, but they don't come to medical care as we would like them to.
Yes, and I think there's similar issues certainly here on the Texas-Mexico border, with more and more efforts being placed to target, Hispanic, Latinos, Spanish language, outreach, et cetera, is becoming so important. And I think that there's still, certainly in my community, there's still a lack of awareness, even in this day and age, and even among medical community in terms of PrEP and just routine HIV screening, right? That it's not risk-based anymore. Everybody should be getting an HIV test. And then, unfortunately, I think a lot of Hispanic culture and background still carries a lot of propagation of stigma and homophobia, et cetera. And so there's still some work to be done in that realm as well, I think. And in your communities, who would you say are the individuals that are more at risk, and what types of policies, efforts, procedures, et cetera, are y'all's communities putting in place to kind of help mitigate these risks? Whoever would like to chime in.
And so unfortunately, there's a number of efforts being done. So if we talk about testing, there has been a number of initiatives. There's mobile units that are trying to go and increase testing. Unfortunately, they don't go to the Latino communities. That is not where they go. And so they're not being reached. And so the physicians are not testing the patients that don't come to care. And when they do come to care, if you are elder, since we're talking about older, you're not at risk because you're older. So if you're over 50, you're not at risk because, you're not having sex. So we're not doing enough for those reasons. There was a large meeting that took place a few years back with a number of initiatives to address the Latinos. It's specifically from testing, identifying, healthcare, all of those, but there has been very little to sort of fulfill some of the initiatives that were discussed at the time. We've come a long way since we started back in the 80s, but we still have a long way to go.
Yeah, I would echo that for sure. There's a lot of education being done amongst providers and community members, a lot of outreach efforts to encourage routine testing, to encourage pre-exposure prophylaxis, but we're still seeing many patients come in with new diagnoses, and I think some of these outreach efforts are clearly failing. Every year we have a patient who comes in with a new diagnosis who tells us that they tried to access pre-exposure prophylaxis from a provider and knew that they were at risk, and yet were either, the provider declined, or for some reason the connection wasn't made and they never received that pre-exposure prophylaxis. So I think that's one barrier one area where a lot of work is being done, but we're still not reaching all of our community. I think the original question was who's at risk, and I think that's actually one of the challenges, is that it's not just one group that is at risk. There are certain groups that are at higher risk. Certainly, we're seeing many new infections among young men who have sex with men, but we're also seeing infections among anyone who has a risk factor, whether it be a sexual risk factor, whether it be injection drug use. There are many risk factors for HIV acquisition, and I think most importantly, even when providers ask about risk factors for HIV, when they're thinking about screening and prevention efforts, what I find is that patients, and perhaps especially Latino patients, are often hesitant to share what their risk factors might be, whether for fear of stigma or judgment, or that ending up in the medical record and then being propagated, or in our community, it's a very small Latino community, and so they're even nervous about being seen in a waiting room of other patients who are there to receive HIV testing or prevention. And so many different reasons that patients may not be open, for very understandable reasons, to sharing what the risk factors might be, and then that represents a barrier to either receiving HIV testing or prevention.
Yeah, definitely echo that down here in South Texas as well. A lot of efforts to reach the public, but also the medical community in terms of education about, PrEP, pre-exposure prophylaxis. And I do have to say that, all the pharmaceutical commercials are definitely helping in that regard. When you can watch your Law and Order and then, your sitcom or your whatever, and then here comes a commercial about PrEP or about HIV treatment, and it kind of helps to destigmatize that. And then, just trying to reach the community sometimes, as has been mentioned, can be difficult because some folks don't want to be associated with that outreach, right? Because it may out them and they may not want that. And so that can become a challenge, but definitely a lot of efforts are being done to expand testing and just get everybody to follow the guidelines, right? And then, as was mentioned, is that even the guidelines say basically between the ages of 13 and 65, like suddenly I'm 65 years old, I stopped being a sexual being. And we know that that's not true. And of course, for HIV and aging, we have to remember that sexual health is health at any age. And so it's important to have those conversations because it's a part of our overall wellness, including our mental, emotional state of being, to be able to have that type of connection, with our partner, etc. And what are, your state and your local health departments doing to serve patients, specifically older adults with HIV? What type of, programs or resources are available in your areas, in your communities?
Within the Office of Public Health, there is a Latino task force which sort of addresses a lot of those issues, but there isn't anything specific to target the older population. It's just sort of all encompassing. And a lot of times they focus on the younger groups because those are the ones that are most affected. But again, we forget the elder. We had sent a questionnaire to all our primary care physicians within our institution, trying to identify what their thoughts in HIV testing. And many of them reply by, I only take care of geriatrics. And so there is a misconception from physicians, from healthcare providers themselves. So the education goes beyond just the public. I think that we need to be educated as well.
Yeah, I think our state and local health departments are doing a lot of work in this area. I think just increased recognition that patients with HIV are living longer. Over 50%, nearly 50% of patients with HIV right now are over the age of 50, and recognizing that they are going to need additional support services and care, and helping to provide those services and care and awareness. Also, just like you mentioned, Dr. Martinez, so the fact that just because somebody's older doesn't mean that they stop being at risk for HIV. And so still promoting testing among all ages. I think there's increasing recognition among the spectrum of ages and needs for people both living with and at risk for HIV.
Mm-hmm. Yeah, and I think it's always important, just to look at the usual sort of, your area agency on aging and heck, the AARPs and, all of those kind of aging support institutions and outreach that's available. Because one of the things too, a large, and we know that not all folks with HIV are part of the LGBTQ community, but there is a large subset that have difference in terms of family and social support, who may not have, the long-term spouse or partner, may not have children. That is a lot of times a fallback for folks that are aging, may not have a supportive extended family or even community of friends. And that can lead to a lot of isolation and a lot more need in terms of just daily needs and living and you taking care of yourself. And so just accessing those usual, things that we would think about for aging and not forgetting that they are there.
Yeah.
And
I think COVID exacerbated a lot of those factors, or that people weren't even able to lean on some of the support services that the very few support services they had in years past.
Yeah, and sometimes you don't know it exists, you can't ask. And so what do you all feel are some of the consequences of aging with HIV?
Sure. So I can start. I think they're numerous. For one, we know that patients aging with HIV are at higher risk from many of the comorbidities that we see typically associated with aging that are occurring at younger ages. And so frailty, cognitive impairment, many of those comorbidities are occurring more frequently and at earlier ages. I just saw a report that patients with HIV are at twofold higher risk for some of these complications, and that correlates with mortality. And so I think that for certain, also patients with the HIV have common mental, the social isolation, the stigma, many common mental health comorbidities, many comorbidities that lead to polypharmacy. And then fortunately, our regimens, we are now able to give many patients regimens that don't include CYP inhibitors, which then result in significant drug-drug interactions. But we still have many patients who are older who are on regimens that contain CYP inhibitors and then not only have polypharmacy, but a lot of really significant drug-drug interactions that can occur as a result. I would just start with that list, but I'm sure you have other things to share as well.
Dr. Hurtado mentioned that, all of the complications, if we look at Latinos, they have high rates of heart disease, they have high rates of cancer. And so that in itself puts them at risk right at baseline when compared to some of the other populations. We see increased diabetes. So I think that they need to be recognized. And as you age, obviously, the complications that go along with that. So the older population starts a higher baseline, and then you sort of tap that with all the polypharmacy that's been mentioned. So it complicates things dramatically, and they do need access to healthcare earlier rather than later, which they obviously did not have good access in many places.
Absolutely. And that's one of the sort of other things, that immunosenescence, the kind of early aging, even if our immune system and that kind of chronic inflammatory state, right? The chronic inflammation that just kind of adds on whatever, say genetic predispositions I may have already had. If I was programmed, folks in my family get diabetes in their mid 40s, I'm adding fuel to the fire. I may get diabetes in my mid 30s, or I may get heart disease earlier. And then all the consequences for quality of life that come with that illness that is compounded by, the HIV status. That's definitely can be challenging. And then balancing all the other medicines and all the other things that also affect quality of life, right? Because we get medication and pill fatigue. And if we've had to start early, and especially I think we see that a lot with long-term survivors, right? That have been in this battle, in this game since the late 80s, the early 90s, and have gone through all the gamuts of regimens, and then also have to deal with survivor guilt. Having lost so many folks, and that carrying that with them as they age for decades can be very challenging, mental health wise as well. And what do you all think that, community and community members can do to help with HIV care and stigma, in general, but also for those who are aging?
I think the one thing I've been trying to share sort of loudly, kind of want to scream off the top of rooftops, because I'm always surprised when either my patients or their family members or friends or medical students don't know this, is the message that undetectable equals untransmissible, or U equals U, or, in Spanish, sharing that message as well. I've had patients in my office who are long-term couples who have still serodiscordant, where one patient has HIV and the other does not. And the patient with HIV has been really living in fear their whole partnership of transmitting to the partner. And when we are able to share the message that we now have rigorous scientific data that backs up the notion that once we achieve virologic suppression, and then there is zero risk of sexual transmission as long as that virologic suppression is sustained, that patients will break down into tears, just at the relief that weight is lifted off their shoulders. And so I think continuing to share that message, not only with our patients, but also with their friends and their family members and our community members, so that really, that self-stigma, that self-fear can be lifted off of them.
Yeah, I think Latinos in general don't talk So the families, and so they don't reach out, and they are certainly, if they're having issues, they don't go to a counselor, they don't go, they might go to their pastor, they might go to the somebody at the church and talk to them. So I think speaking and discussing those issues are very, very hard. And a lot of times the family doesn't know. They get the diagnosis of HIV and no one in the family knows. I had patients that they did not even disclose it to their partner, which creates all sorts of legal issues. And so the sort of that discussion and to be able to interact with the community is challenging because they don't reach out for those for a lot of that what's available to them.
And I think that's another, area that helps a lot, like with the promotores de salud and et cetera, who can go to church settings, more, community settings, and are already kind of accepted, by our Hispanic and Latino culture as folks who go out into the community to promote health, and adding in that sexual health or HIV component, because that can help to make us more comfortable with talking about it. Because in general, in Hispanic cultures, any sex talk is taboo, but we all know we're having it because we have large extended families, right? And so it's one of those things of making it acceptable to talk about it in a way that we're already used to. And I think that that also goes a long way to break the barriers of stigma, because I think unfortunately in our communities, a lot of folks die of embarrassment. A lot of folks don't get tested because of embarrassment. A lot of folks are very late diagnoses and presenters because of that. I know I see that in our community, 52% of all of our patients are advanced HIV, and it doesn't need to be that way, right? It doesn't really need to. And so hopefully we make grounds in our communities to help prevent that.
And just along those lines, one of the most heartbreaking cases I've had recently was a patient who has had longstanding HIV, but has not been able to share with his family members and friends for all of those reasons. And he ended up developing a lymphoma. And it was finally when he developed lymphoma that he could share that diagnosis and then receive care and support. And then because he had all that care and support and saw that he had that unconditional love, he was then able to disclose the HIV diagnosis and finally came in for regular care and did much better. But it was heartbreaking that it took a diagnosis of cancer for him to be able to share with his friends and family.
Mm-hmm. Yeah, and sometimes that makes it acceptable, right? Well, I had cancer, or I had this, or I had that, and then it was pneumonia. And then eventually maybe that will lead into the actual discussion of the HIV diagnosis. And what do you all feel are some of like the barriers, especially for older individuals, with HIV experience, and what are some of the best practices to overcome these barriers, barriers in getting diagnosed, barriers in coming to care, et cetera? What do you all experience in your communities?
I mean, I think that you mentioned something that 50% in your community don't get tested. They're sort of latecomers. Some of our numbers are 70% that are sort of late coming to, having AIDS diagnosis at the time. So how do we get them to come in earlier? How do we get them to do that? And once they sort of seek care, how do we get them to share? So it's very challenging, once they get trusted. The other one is the language barrier. So having providers that speak Spanish is very hard to have a conversation with an interpreter, trying to be able to communicate some of those hard issues, and not just from the providers, but also social workers, someone that they can identify with. So that's all very challenging to be able to have those. We have a lot of interventions in the community, but a lot of times we sort of forget about that language barrier, and that they are not able to sort of communicate. The Latino population here is very mixed. I mean, we have people from Central America, from South America, we have from the Caribbean, and all of those cultures are very different. And so in trying to reach the populations, it's not just one, they're all different in terms of some of their thoughts and beliefs. So for all of those things, it makes it very challenging to try to intervene in all of the groups just because of heterogeneity.
Yeah, and I would add just something that really became prominent during COVID diagnosis and treatment was just reminding patients that just because they come in for HIV testing does not mean that their immigration status will be revealed or that they need to present documentation in their papers. And so really removing that fear and that as a barrier to testing and engagement in care has been really important and has made some impact in our communities.
No, yeah, absolutely. That has definitely been an issue, especially here on the border, where folks are hesitant because of fear about immigration status or that they're undocumented and therefore could not qualify or could not access services. And of course, that's not true. There is a question here that's coming in the Q&A, and it says, do you feel that providers would benefit from cultural sensitivity or competency trainings when addressing the aging Hispanic population?
I would say I can go ahead. Oh, go ahead.
It's a resounding yes. And so yes, I mean they do, and I think that not just for the Latino population, for the older population, but for all, yeah, and they need to sort of be aware, just like the provider I mentioned earlier. I don't have any patients that are at risk because I only take care of geriatrics. I mean, that obviously, then there's education that needs to occur.
Yeah, I agree. Resounding yes. And, I think not just for Latino populations, implicit bias training for all of us, for, to recognize our own biases and really be thoughtful about that when we're approaching the care of any patient is critical.
I think one of the things, and especially like us, we accept federal dollars, right? We're a federally funded Ryan White clinic. Anybody who receives federal dollars, really, we should be, and anybody in general should be looking at the class standards, right? They're there for a reason. It's not just another training to check off boxes, because it can make a big difference for patient outcomes and right? We like to have good patient outcomes, but just, culturally, linguistically appropriate service delivery models really are important, and reflecting the community that we serve. I know in our clinic, in our area, we're largely Hispanic, largely of Mexican descent, and we have a lot of folks who are Spanish speaking only. And of course, we serve the LGBTQ community, et cetera. And our staff, we reflect that, and it makes it easier for someone when they feel like they fit in, or at least can recognize themselves in someone in the staff, right? In the folks that are helping them. I think that goes a long way to having that trust. And then if you have already a foot in the community with that person or that family, then that helps you to reach more folks. There's another question also in the Q&A, and it says, do you see a difference between treating the aging Hispanic population versus younger population?
I would say the biggest difference I see is just in communicating with patients, especially after the visit, which a lot of our care takes place after the visit is over, sort of reviewing lab results, discussing changes, discussing things. And with my younger patients, no one has voicemail, no one checks their voicemail if they have it set up, and they all respond really well to text messaging, or at least through our patient portal, the messaging through that system. They'll often respond multiple times a day, whereas my older patient population has a harder time just generally, setting up the portal, responding to those messages, and really prefers phone communication, which that's just something I've found generally as a.
Yeah, I mean, the younger population certainly have less comorbidities than the older population. So our focus is a little bit different between the two, and depending on the generation, so where you are, their thoughts are a little bit different. Your older population needs a little bit more of, not necessarily explanation, but they're used to their provider sitting there with them discussing, what your younger population, they just want to know the results and get out the door. A telemedicine, consultation is fine for them. And your older they come with a list of questions that they want to address with you. So they're very, very different in terms of communication and the issues that need to be addressed between those two.
Yeah. I think another thing that I see too is that it can be, call it easier, if you will, to have those sexual health discussions with the younger population than with the older population. And sometimes not even necessarily on the clinician level oh, I feel uncomfortable asking you these things. I know I've had experiences where they take offense that I'm asking these things, and especially myself being younger than they are, like, how dare you, mijita, asking me these things, you know, like that's none of your business. And even just trying to get them comfortable with talking about things, about why it is important to have those discussions, and why it impacts their health, and that, you know, we're just looking for health, and that can sometimes be a barrier to overcome as well. And one of the things, you know, there's another question is, you know, what are some that you feel tangible solutions to overcome, you know, late diagnoses among older adults and in the Hispanic community?
I think it's really hard. We just, we just had a report, actually, very interestingly, it probably a little more unique to Nebraska, but we, our latest data from last year showed that we had more rural diagnoses, and the rural diagnoses were much more likely to be late diagnoses. And so I think it's something really important to be talking about and addressing in any venue that we can. I don't know what the best solution is besides continuing to educate and really encourage both patients and providers to get tested, and get tested frequently if they're at risk. You know, we have many patients who come in for care who have been testing regularly, and they know that they're at risk, and they will still end up testing. But then we have the more concerning, the reason for the late diagnoses is the ones who have been at risk for years and years and had encounters with the healthcare system, whether it be with the ER, with the sexual health clinic, with multiple different opportunities for testing, and still no one sent the HIV test. And so I think the more we can educate both providers and patients about the need for regular, universal, and frequent testing, the better.
Yeah, I mean, we did so well with universal hepatitis C testing, and we can't do the same thing for HIV testing. So we instituted a pop-up window that everybody who had not had a hepatitis C testing will have a hepatitis C antibody, and we're not able to do the same thing for HIV. So we looked at our patients that had a diagnosis over a 5-year period, and every one of those patients, like Dr. Hurtado mentioned, had at least 7 encounters with the healthcare system prior to the diagnosis, one of which was just classical acute retroviral syndrome, and no one thought of doing an HIV test. When we looked at all of syphilis diagnosis, only 20% of those that came in with syphilis, regardless of age group, had an HIV testing. So, I mean, it's just, if they're coming to the healthcare with something that is sort of with a positive, whether it's GC, chlamydia, and they don't get an HIV test, I mean, that is on us. And so we need to be able to, you know, we need to be able to do much better.
Yeah, I think it's really interesting what you're talking about, because we have this broad goal of universal testing, and we are not even seeing testing when it's indicated for risk-based testing. So I feel like we're years behind where we should be. We see the same thing where our patients will come into different healthcare systems in town, to ERs and other areas, and get STI testing, but oftentimes providers won't perform the HIV test because they're afraid of opening up. You know, they'll say, well, that requires a lot of follow-up and another confirmatory test, or for whatever reason, other STI testing will get done, but not HIV testing.
Yeah, I think that's the funny thing. The way I say, you know, talk to the patients is anyway and anywhere you do sex stuff, you can get sex stuff. So if you can get one form of sex stuff, you can get the others. So it might as well test for all of the above, because the way they're passed from one person to the other is the same, and it's not a judgment, right? It's just, if you can get this one, you could get these, so let's just be complete and not miss anything. And then that goes back to that comfort about having those uncomfortable conversations, which sometimes is unfortunate because we're all human and we can all have that, you know, discomfort about talking about, call them intimate things. And I think another question that's important, you know, to ask is, you know, is HIV stigmatization universal across all age groups, or do you find that there's more about one age population that seems to be more affected by that stigma than others?
Probably the older population, I think the younger ones perhaps is getting a little bit better. And I guess it depends on where you're talking about, but in Latinos in general is probably by its comparators, whether it's different, it's still different, although it may be worse for the elderly, but they still don't want to talk about it. They get diagnosed and they don't discuss it with their family. So which goes back to all the things that they could have access to and they don't because of the embarrassment that they have.
Yeah, I would tend to agree. I definitely think that those who grew up in the 80s and lost friends or family members to HIV, there is a little bit more stigma still, or those who experience forms of discrimination because of their sexuality or gender identity. I think that we have made progress in those areas. And so the younger generation, there's a little bit less, but there's still a lot more. We still have a long way to go.
Yeah, I often do some talks about, Latinas, Hispanas and HIV. And, one of the really good things is how few, Latinas test positive, have a new diagnosis every year, about roughly 1,100, 1,200 in the US. The other side of that is that it's very isolating, and you don't have an automatic support group, and there isn't marketing towards you, right? You don't get the warm hug of, oh, look at all these posters and look at all these things that are geared towards people like me. And I think that's very similar for just in general, folks who are aging, right? In great with the commercials, and some of them are doing better at having that representation of the older adult, with HIV and living, their best life, their quote normal life. But we need more of that too, because unfortunately we do still have folks that are being diagnosed later, and that, these late diagnoses, they make a big impact in long-term health and quality of life. And so obviously we still have those barriers to kind of work through. There is a question in the chat. Have you had older patients who were identified in the hospital setting through blood work while awaiting care for other medical conditions? In other words, they were there for something else, had a routine HIV test, and then are coming out of that visit with a new diagnosis.
We have, and go ahead.
Oh, no, I was going to say the same thing. We absolutely have. And we've had both scenarios. So we've had patients who were diagnosed, were here for something completely unrelated and had a routine HIV screening done that ended up turning positive. But we've also had, I've been really proud of some of my trainees who have performed HIV screening in patients who presented with something not obviously related, or that would have been an obvious reason to send an HIV screen. So for example, a woman who had no apparent risk factors for HIV, who presented with severe pneumococcal disease with bacteremia, and remembered that was an indication to screen for HIV, not your classic thrush or pneumocystis pneumonia, or one of the classic OIs, but some of the other conditions that can absolutely occur as a result of HIV or depressed cell-mediated immunity. So absolutely, and on both sides of the spectrum.
Yes, I've had a similar case. I had a gentleman who had gone to get his routine colonoscopy, who's a little bit later in his 50s, and it was abnormal, and was actually in the hospital for more biopsies and workup for colon cancer. And so in that workup at the hospital, they did run an HIV test, and they come and tell him, so how long have you had HIV? And he was like, I'm sorry, what? Like, this is the first time I'm hearing anything about HIV, and you came in assuming that I knew, and that I was like out of care. But that was how he got his HIV diagnosis. How long have you had it? And I'm like, I haven't, and that's a very traumatizing experience. Not only did I just in the last few weeks find out that I have colon cancer, and I'm going through all this workup now, and staging and all this, but you just kind of just toss it at me. Oh, and I have this now as well. And so I think that's one of those important things also, like we need to kind of reevaluate our bedside manners sometimes, that it's maybe matter of fact to us. I know, like for myself, because we do have a lot of advanced HIV, I'm completely unfazed now by the CD4 of 4 or the CD4 of 0. But that is something that is very frightening and very concerning for the person, whose lab that is, whose state that is. And so always remembering to have that compassion and that kind of the think before you speak, right? That sometimes we forget, especially when we're rushed and have to go from patient to patient, etc. Another question that I have here is, what has been the progression of development of antiretroviral treatment throughout the years, and how has that impacted individuals living with HIV? And specifically, how does it relate to adults aging with HIV?
Well, for some of you, perhaps you don't remember when our patients used to take 30 pills a day. And not only 30 pills a day, when we had some liquid formulations that tasted horribly, or the ACT that were 5 times a day. So the new generation doesn't remember any of that. So a single pill a day with less side effects, it's great and wonderful to be able to do that. Increases adherence and all sorts of things, and certainly it's much easier with comorbidities. So a single pill a day, that they can take. So it's all of that is very welcome currently, and it's certainly for the elderly population, it's great as well. They already have enough pills to take, so to add one more as opposed to 6 or 7 more, it's very welcome.
Yeah, I would say I agree. I tell my medical students, my residents and fellows, that one of the many reasons why I love working in the field of HIV is because we've made so much progress. We just celebrated, well, or I don't know if celebration is the right term, but we just marked 40 years of the HIV epidemic last year. And to think that we have come so far from having, at first just one antiretroviral, zidovudine, with so much toxicity, such significant toxicity, and not terribly effective on its own, to now, one single tablet regimen is really the standard of care for patients, and what almost all patients can receive with really minimal toxicities. I mean, I think it's a real luxury to think about the toxicities that we're now thinking about are weight gain and metabolic complications, as opposed to the really significant toxicities that would require discontinuation of therapy. And I think, we're continuing to see progress. Just in the last couple of years, it was buried in the headlines, but the fact that long-acting injectable therapy is now an approved therapy for patients who, who, especially the patients who really face that pill fatigue and that self-stigma, where it's really made a life-changing difference for them. We've come so far, and the pipeline's still growing. So it's a fun field to be in, and to be able to offer patients therapy that's so effective with minimal side effects and toxicities.
Yeah, absolutely. I have those, like with the new patients, the HIV care in this day and age is so much different than even just 10 years ago. It is certainly different than 20 and 30 years ago. One pill a day was a miracle, when it came around in 2006. And it changed lives. It really absolutely did. It changed lives. And the fact now that it's not survive at all costs, it's thrive at all costs. That's really where HIV treatment is. And the pipeline, as you mentioned, things are coming in, fewer medicines, longer acting, a lot more options. And, talking about the long acting injectables, I had a gentleman this last week who's been in therapy for about 20 years now for, HIV care. And he was, he jumped at the bit to get on long acting. And he said, I can finally feel normal. I don't have to worry about it anymore. And he swears he's never missed a pill because it has always been on the back of his mind. No matter what, I have to take my pill today. And I mean, that is just, it makes me feel good, that we can help in that way. And then it also kind of makes me a little bit sad that he hasn't felt normal in the last 20 years, even though he's recovered well and he does well, he takes care of himself. But it's one of those things that pipeline, there's more to come, and hopefully we get a cure, but there's more to come.
Yeah.
And what do you see in the future for individuals with HIV? We talked about pipeline, but in general, what do you see as the future of HIV, both for, the younger new diagnoses and for the aging population?
Well, I tell my patients as we sort of kind of have gone through the journey for the last few years, I'm not going to be there to have the discussion about the cure. Is that going to be a discussion that I'll be able to have with my patients in this lifetime? Less pills. The injectables is a great thing. They'll see you, they'll come in every couple of weeks, perhaps longer, who knows? But to have that, so when they take that pill, one of the things they say, it's not the same thing as taking their high blood pressure pill. Every time they take that pill, it's a reminder of their diagnosis. When I take my blood pressure pill, it's just a blood pressure pill, and is that going to change? Will they be able to get a cure in this, within the next few years? Unfortunately, COVID happened, and a lot of the research across the board, including HIV, sort of took a hit, and things kind of stop. So can we get back to some of those goals that we had before?
Yeah, I always tell my patients that my dream is that we'll have a cure, in my lifetime. I'm not sure. I think, we're maybe closer to finding a cure than a vaccine. But I also think that we've made really significant progress. One of the biggest areas is in HIV prevention, and with long-acting injectables for prevention, we almost have a pseudo vaccine that has to be given more frequently than just once, but that I think we'll continue to see progress in the area of prevention. I think in the area for where we're going to see progress for patients living with HIV is, again, I think therapy will continue to get easier for the patients to take, to tolerate, and we're really in this place where we're able to think about toxicities that are more, in many cases, more theoretical than actual experienced by the patient. And so I think we're going to continue to see people do better and better as they age with HIV.
And we have one more question from the audience before we wrap up. And it says, what methods have you seen that increase treatment adherence among the aging population?
I'll say one thing that has been really effective for those aging with multiple different complications of aging, so everything from vision to dexterity to other issues, is many pharmacies are now offering adherence packaging or blister packaging, and that has been really life-changing for many of my patients aging with HIV. So the pharmacy is able to put all of their medications into these blister packets that are organized by, they can be offered multiple times throughout the day, and they give them a week's supply, or they give them often a couple weeks supply at a time, and they just have to pop out the medication. So instead of a family member needing to come and fill a pill box and using old discarded pill bottles, things that would have been expired, it's always up to date as long as the pharmacy has an active medication list. And so that's been really life-changing. And then the pharmacy can see if they're returning the blister pack with some unpopped, see the real adherence, and then communicate that with our care team. So that's been one of the most effective interventions that I've used.
I think that's a great thing. So a few years back, probably about 2 years, my mother is 90 years old, and she told me that she was doing fine with her medications. And we forget that it's difficult to do. It takes me an hour to put her pills together. That's how long it takes me. So by the time you start going the once a day, the twice a day, her thyroid pill has to be half on Sunday. There is no way our elderly can accomplish that. No way. And so we forget when mom, dad, or grandpa tells you that they are doing fine, they're not. So having those packages is great. And if you don't have access to that, having a caregiver that actually oversees the medications so that they are able to take it properly, because they're not just taking that one a day pill for their HIV, they're probably taking something else along with it. So overseeing and being able to do that as well really helps.
Absolutely. We've utilized those, the pharmacy packaging systems, and then also a number of pharmacies have those kind of adherence programs where they can call and check in, and that becomes very helpful as well. So I don't see any other questions that have come in from the audience. So we'll be, kind of wrapping things up. And firstly, I'd like to thank our guest speakers for their time and expertise on today's topic, as well as our live audience for participating today. We thank you for those questions. A recording of today's discussion will be added onto the NHMA YouTube page within a week, and we hope that everyone enjoyed our robust conversation. We invite you to please join us for our upcoming events that you can see here on the slide. In October, there'll be the NHMA Health Disparities with Severe Asthma in the Hispanic Community webinar. There'll be a COVID-19 virtual briefing series as well in October. And upcoming for next year will be the NHMA's 26th annual conference in Chicago, and also the NHMA's Vaccinate for All campaign is ongoing. If you have any questions regarding the HIV program, please reach out to the program manager, Jason Hernandez. And we thank you all again and enjoy the rest of your day.